Thank you. So welcome to the Missouri Coalition for Oral Health online training, Stepping into the Future Now, Innovation through Teledentistry, Part 2. My name is Ashley Herman, and I am the Community Outreach and Project Development Director with the Missouri Coalition for Oral Health. CEUs for today's webinar are being provided through CE Zoom, and just as last week, a code will be provided at the end of today's session. CEUs are only available for those attending the live sessions as well. There will be a link sent out after part 2 today for a post-session survey. We ask that you please complete that to help us establish the impact of this training and to provide any information for improvements for future sessions. CE Zoom will also have a survey for you to complete for the CEU purposes, so you'll see 2 different emails. We would like to thank the Missouri Office of Dental Health for sponsoring this online training and to Access Teledentistry for partnering with us. We would also like to thank the Missouri Office of Dental Health and the Missouri Foundation for Health for supporting the registration raffle prior to Part 1. Congratulations to those attendees who received a mouthwash intraoral camera system. The Coalition has long supported the development and implementation of teledentistry in Missouri as a way to increase the access to care in Missouri's underserved areas. It is our goal to see teledentistry utilized widely across the state of Missouri. Our presenters for today are Dr. Nathan Suter and Tiffany Grant. Their complete bios can be seen on the Access Teledentistry website located at www.accessteledentistry.com. Dr. Nathan Suter is the chair of the board of Missouri Coalition for Oral Health. He has served on the board since 2014 and also chairs the conference committee. He is the chief executive officer of Access Teledentistry, a company he started with Tiffany Grant. He is the former dental director with Comtree Comprehensive Health Center, a federally qualified health center in FQHC. He advocated for the establishment of teledentistry in Missouri and started the first teledentistry program within the state. Dr. Suter is a graduate of the University of Missouri Kansas City School of Dentistry. Tiffany Grant is the Chief Operations Officer of Access Teledentistry. She had a 16-year dental career as an assistant, a hygienist, and a dental educator, and she served in the United States Air Force and worked as a dental educator and community oral health director, where she successfully created and implemented several prevention-based initiatives and programs. Tiffany worked for Comtree in Jefferson County, Missouri, where she was integral in implementing oral health and primary care integration initiatives and the teledentistry outreach project. With that, I'm going to turn it over to Tiffany Grant to start today's presentation.
Hi. How's everyone doing? It's kind of awkward a little bit because I don't see everyone's face, so I feel like I'm talking to a blank room, but we're going to go ahead and get started. I'm super excited to be here today to share this information with you guys, and hopefully you find it inspiring. Hopefully you leave here feeling creative and ready to implement some teledentistry or do some kind of innovative dentistry in your setting. So, Dr. Suter, can everyone hear me okay? I don't know if I hear other things. Dr. Suter had a family emergency this afternoon, so the first part is a section that he was going to finish up from last week, and I'm going to go over that briefly, okay? We're going to go over operations of teledentistry. Sorry, I feel like I might be frozen here. Okay, there we go. So when you're designing a program and you're planning, there's several things that you have to consider. Some of the things we have listed here, like what kind of consent forms you are, because most parity laws for teledentistry require some kind of consent to let the patients know that they're actually doing a teledentistry assessment or exam. You have to have policy and procedures, and one thing I always like to know with the policies and procedures, it should be to the same standard care of traditional dentistry too. And then you have your operations and workflows, and as you can see, we have an example here. This was the example that we used when we were at Comtree, the Federal Qualified Health Center, of how we moved a patient through the teledentistry process. So obviously these things will be very unique to the setting and to whoever's working with them, and it can be done very differently. So it's important that you kind of start to write a policy. A policy will always ensure that all processes are formalized and meet all requirements. And what we also find too is that if you're turning over a program to someone, that the policy and procedure manual is very, very helpful, or you're introducing someone to your program. This one we feel like is very, very big. It is make sure you have your support staff buy-in. And with that, if you don't have their support, you might have issues, especially they kind of sell it to the patient. So you have to they have to believe in it in order to sell it, I always believe. But it's important to provide them with the script. And here we have our script right here that we use. And it's important to tape it. Oh, well, you can tape it below the screen. Like our current script says, due to COVID-19, we are currently seeing one patient at a time, and Dr. Suter is triaging patients through Tiffany's chair or teledent exams. We are limited on how many people can be at the office at the time. Coming in for X-ray with Tiffany or teledentistry exam will help Dr. Suter understand if you need to be referred to a specialist or what type of appointment is necessary. So that's a phone script that we use here in the office to kind of help the support staff and inform the patients about exactly the process and what we're doing here. So your policy and procedure manual is a step-by-step guide. Your procedure manual is a step-by-step guide. It's a formal document. It has the job descriptions of all staff members, even your front desk staff, if you have hygiene assistants or you have treatment coordinators, all the job descriptions should be in this procedure manual. It outlines the teledentistry workflow, like how are you intaking patients, what's the process of scheduling in your teledentistry program, do you have the necessary documentation, the equipment that is used, and an inventory and pictures and descriptions, which like when someone is taking over a program or new to the program, it's important that they see kind of how everything is lined up and how everything is used. This is the to-go manual on how to use or how to work within your program. It data captures the steps. It shows like what kind of note requirements and what kind of examination requirements and the different requirements that you have within your teledentistry program. So this is an example of the training manual that we use, or either the procedure manual that we used when we were at Comtree and we created. So calibration of the dentist and the hygienist. This is really important. We found that when we first started to pilot teledentistry, that it was very important that whoever was what we call the facilitator of the case or the case presenter, that they were very in line with what the doctor felt acceptable. Just like in a regular setting, if you're working with your dentist, you want to know what type of x-rays they like, how do they like to x-rays, what information is pertinent to them, or what information do they look for when they're doing examinations. You study kind of the things that they want in order you can have better outcomes when they're doing the exam. But it's really important that the information that is given to a dentist during teledentistry, that they feel confident enough to provide a diagnosis. And so that's why that calibration between the dentist and the hygienist is so important, because if they don't feel like the data is sufficient, then the exam can't be done. Training schedule. The hygienist and dentist needs to know the process. Typically, they should train together and work closely together. The more time they spend together, the more calibrated they will be. As far as Dr. Suter and I, we've been doing it for 5 years. So I feel like we're pretty calibrated, and still we're always tweaking and modifying, and he's always giving me feedback, even 5 years after 5 years doing it. So it's a process that continues to happen. Front desk staff, they have to know that the patients need to be notified that this will be a teledentistry exam. There's some coding differences. It's even like when you close out certain codes. The paperwork consents are a little bit different, and the scripting needs to be clear for sure. Care coordination system with teledentistry is so important, because the dentist is not here, and you might not have other key staff around you. You have to make sure that the whole process is still very comprehensive and the patient's needs are met. So make sure you have a good follow-up care system. You have clear documentation. You have to make sure that coding can ease the appointments and planning process. So when you're looking at your teledentistry program, which is kind of like what I was talking about just the slide before, when you implement, then you have to evaluate. And like I said, even 5 years of doing this together, we're constantly implementing and evaluating and trying new things and evaluating the process to see what we can do better. So after you plan, you have to do research. You have to find out what the stakeholders are. Typically, when we do consulting, these are the kind of things that we're looking at. We're looking at budgets. We're looking at different stakeholders, outside, inside people who will be involved with the teledentistry program. When implementing, you have to look at purchasing equipment, organizing equipment, training staff, enrolling people into the program. You launch it. And then you adjust, you're tweaking, you're trying new things, you're timing things, you're taking notes and continuing to adjust, readjust, and then you settle in. I feel like even because it changes, like if you think about like how COVID might have affected our workflow, we had to go back to readjust and settle in. So it just depends on what's happening with your program. Let's say you get a whole new demographic, like a nursing home. You start off in schools, but now you're going to nursing home, then you might have to go through some of these steps again. So these are really important questions that you need to ask yourself. What are your goals? Is your goal to find new patients, reduce provider travel time, increase access for existing patients, reach new target populations, like I was saying, like the nursing home? What are your other reasons? You have to always keep that in mind when you're kind of strategizing and going through the phase of implementing a teledentistry program. And I think you have to keep these things in mind when you are launching the program and adjusting and tweaking. You just have to keep your goals in mind. So review of revenue from service delivery. These are some things that you have to ask yourself when you're looking at your budget and your bottom line here, and seeing if teledentistry can fit in your practice. You have to know what procedures would you perform at a typical visit, how much do you charge for those procedures, and how much would they generate per year. Sorry. Back a little bit. Sorry. Definitely overclick there. So we'll go into reimbursement. Coding guidance, if you're providing care for telecommunication technology to triage patients or offer an evaluation to determine if the situation is urgent or emergent, then the following codes can be used to document and report the services in the patient's record or to a third-party payer. So this is what we use for oral evaluations. The periodic, we typically, for the periodic, we typically use the D0120, and that's for recall patients. If we have a new patient, we use comprehensive evaluation. Can everyone hear me okay? Because I see some subtitle stuff coming on here. Can someone confirm? Gary, can you confirm? Or
we can hear you.
You can?
Yeah.
Okay, great. Okay, so you have to confirm, these are different type of oral evaluations that you can do. Comprehensive evaluation, sometimes it's difficult to do that because typically if you have a new patient, they want to see the doctor in person, so we don't really use that often. But if you were in an outreach program, you could use that. Like if you were in a school outreach program, then that's one that you may use. But if you were in a clinic setting, typically the patient wants to see the dentist for the first time. Limited evaluation, problem focus, or reevaluation. Let's say if you were doing a periodontal reassessment, that's where you can use a reevaluation code, or postoperative office visit if the patient had an extraction and you wanted to follow up. Please be patient and let the thing move so I won't jump several slides. Sorry about the technical difficulties, guys. It won't let me move forward right now. Okay. Here. Okay, so go back right here. So some more coding guidance is when you're providing services in a teledentistry environment, you have to use one of these codes. Teledentistry, the D9995 is synchronous. That means a real-time encounter. That's kind of like used during limited evaluations where you might be on a Zoom call with a patient and it's happening at the same time. And then the D9996 is asynchronous, where information is stored and forwarded to dentists for review. This is considered the more traditional type of teledentistry code and what's used in dentistry a lot. And these are the two teledentistry codes. Unfortunately, for those two codes, mostly Medicaid pays for them, especially in the state of Missouri. There's no like private payer or Medicare coverage for it, and this is the rate for it. And so, yeah, that's definitely something to consider when you're putting your teledentistry program together. But I always like to say, just because your private payer may not cover this code doesn't mean that your teledentistry program won't be profitable. So the business analysis. So when you're looking kind of at the different type of procedures that you do, you want to look at, like, what are you doing the most? Like, for instance, you see here that 45% are diagnostic procedures and you make $50,000 monthly, I mean, you make 22,500 in diagnostics monthly. You look at how many days are you currently doing diagnostics, and what can you add with teledentistry to increase those diagnostic procedures. You can possibly add 4 more days of hygiene, and with that, there's a 33% increase in days, and then you have almost a 30,000 increase per month. So those are things that you could consider. Sorry, guys. Okay, make revenue projections. So we commonly do this whenever we have, when we do consulting and we're looking at a teledentistry program, our traditional portable program versus the teledentistry data. And we make revenue projections. We look at things like how many hygienists are in the program. We look at the number of hygiene days per month. We look at the dental exam revenues. We look at treatment revenues, and we try to do a revenue projection to see if the program will be profitable. And it kind of lets you also know what you have to do in order to make the program profitable. You can make cost projections so you know how much the program's going to cost. So, I was kind of talking about how Dr. Suter and I work at Dr. Suter's private practice, and we do quite a bit of teledentistry. Before COVID, we used teledentistry whenever he was not in the office, if he had to do a presentation, or if he was out of town, or if he was sick, then we would not cancel the recall patients, and or the hygiene chair, and we would typically be able to see the adult recalls and child recalls, peril maintenance, things like that. So this is kind of, he had 3 operatories, and we all worked together, and we in the office together, and this is kind of typically what our schedule would look like. So now post COVID-19, things have definitely changed. Right now, we have kind of split the staff so that to ensure there's no exposure to COVID, or the whole office doesn't go down if one provider is exposed to COVID. So currently, Dr. Suter works on Mondays and Wednesdays, and I work on Tuesday and Thursdays. So our op looks a little bit different. So where you see treatment op and treatment op 2, that's typically what the schedule looks like on a Monday or Wednesday that Dr. Suter is here. Then he has a virtual operatory where he can do some synchronous consultation where he can talk to a patient while he's in his office. And this is typically what my schedule looks like on a Tuesday and Thursday. I do a lot of adult recalls. I do some teledentistry limited evaluations, keep my peril maintenance appointments. And you can see that even though we have actually eliminated how many to the previous schedule, we did that, and we were in office Monday, Tuesday, Thursday, and half a day Friday. Now we only work on 4 days with not the same amount of staff. And you can see that we're still, with the teledentistry visit, we're still able to get 19 total visits, even though we're not like set up like we were pre-COVID. So I hope everyone understands that. So this is how post-COVID, how Dr. Suter's schedule kind of looks. in the aerosol, he has an aerosol procedure chair where that operatory is closed off. And then he does non-oral aerosol procedures on the second op. And then here you see this column in the third operatory. That's all the teledentistry assessments that he does that I did the prior day. He does the exams on them the next day when he comes into the office. So you can see where those are all the patients that I saw the day before, and he does the exam on them the next day. So, and then you see the virtual operatory too, where he can do also synchronous examinations too. So right there, we're just illustrating that the virtual operatory is where he can do the synchronous examinations, and the other part is where he does the asynchronous evaluations from the day before. Also, too, we found through the process of developing workflows with teledentistry that how important the follow-up is, and it's probably better to use some type of project management system in order to manage those patients. Currently, Dr. Suter is working on a project management system that he's developing for teledentistry called Hillier. And so this will help the follow-up process and make sure that no patient's left behind, because it's harder, as you can see on the previous slide, that in the dentic schedule, it's hard to make sure that the patient got everything that they needed and that they got referred where they needed to go, they got the follow-up appointments that they need. So that's why you can use one that's out there like Monday, or there's various ones out there, but we're developing one that's more healthcare minded, a project management system that's more healthcare minded. So if you look at Q3, you can see how our teledentistry, Q2 and Q3, you can see how our teledentistry has increased post-COVID. And you can see also what that breakdown was, what mainly were we doing. There was a lot of limited evaluations, and 24% of it was recall that we did. Okay, so I'm going to go ahead and go to the next PowerPoint. So I'm pretty excited to go into my part. This is kind of like what I do on an everyday basis. I feel like Dr. Suter likes to really talk about theory, operations, financials, and things like that. But the part that I feel like I'm very, very good at is the practical applications of teledentistry. So that's a little bit about myself, even though Ashley did a wonderful introduction. And we're going to go straight into the type of teledentistry visits. So you've sat in this presentation for the last week and today, and you're kind of wondering, okay, so I got all this information, now what can I do with it? So I'm going to kind of jump into that. These are the different type of teledentistry visits that you can actually do. You can do patient to dentist, and you see that a lot with the post-operatives or limited evaluations. Hygienist to dentist, and you see that with your recall systems. You can also see that with some unlimited evaluations too. You have medical provider to dentist, you have allied health provider to dentist, and dentist to specialist. Here's some actual teledentistry applications. These are the ones that we've been tweaking this list for a long time, and this is kind of what we come up with, and we think it covers everything that you can possibly apply teledentistry to. Limited evaluation and triage, hygiene assessment, satellite office coverage, patient consultations, outreach teledentistry, specialist referral, medical and dental integration. So I'm going to give you a little bit of a scenario with those different kind of applications. So for the satellite office, typically you have an 11-year-old of record with low caries risk presents for a regular recall and preventive care. The dentist is at the main location providing general supervision of all hygienists at the satellite office. The patient has no pain, and the parent's glad that the child can receive care at the office near her middle school instead of traveling across town to the dentist's office, to the office where the dentist is. So the process of what that looks like is that the patient was scheduled for 6 months. A digital form was sent with the update health history and obtain consent. The patient sees the hygienist for updated bite links as well as a full set of extraoral photographs. The hygienist provides the cleaning, the fluoride, the sealants on the 2 newly erupted molars. You are at the main location and a message is sent. If you can jump in on the webcam for discussion with the patient and parent, you can do that, especially if there's like a small ortho consult that you're doing. Or you can choose to review the new and existing radiographs as well as the photographs after the appointment. So you can do this like asynchronous or synchronous. So this type of visit is considered a hygienist to dentist. It can happen at the satellite office, and the case presenter would be the hygienist. There's some different codes that you can use at a satellite office application of teledentistry, and obviously it's considered asynchronous. We have this scenario of limited evaluation and triage. Situation would be that like a 35-year-old female patient of record was eating and noticed a piece of filling had come out 2 days prior. The patient is experiencing lingering pain with drinking cold drinks and has been keeping her up at night. You are in the office today, but you do not have availability. So she can go to your website, which if you look at Dr. Suter's website, Greenleaf Dental, you can see that he has an area where you can click for a teledentistry evaluation. They can fill out the consent online in the questionnaire. And then typically we look at the digital form and ask the patient to send a photo when they actually fill out the digital form. You have the ability to upload a photo. In your outcome, you're able to review the digital form and the image. If there's any existing radiographs on file and you have access to your operating system, you can take a look at that. The tooth in question is maxillary molar, and between patients you can create a referral, give it to your treatment coordinator. You recommend that the patient go to an endodontist for root canal therapy and ask the staff to follow up with a crown after the root canal. So this is considered asynchronous, patient to dentist. The originating site is the patient's home, the presenter is the patient, and here are some coding that you can use with that. The asynchronous code and the limited evaluation. So scenario 3 is the dental hygiene assessment, and you use it during limited evaluation, which I actually really enjoy doing, and I do it quite often in the office here. A 56-year-old male comes for a same-day emergency appointment. The dentist is out the office, and it is a hygiene-only day. The patient has some pain and slight swelling on the lower left. The dentist is available remotely to review the diagnostic data. The patient calls for a same-day appointment. A digital consent and intake form is sent to the patient. The patient comes in for a bite wing, periapical, and an intraoral photo for 21. So what's the outcome? It's that the tooth in question has a periapical image, and the tooth has a very large restoration that has spelled. The hygienist listed in the note that he would prefer to have the tooth removed and is interested in a new mandibular partial. The dentist develops the treatment plans and sends it to the patient to sign prior to coming in for the extraction. So those are really fun. If you have different outreach program, and we use the scenario of the nursing home, but definitely there's different outreach programs. A lot of us have school outreach programs, so you can apply it in that way. You get a phone call from a local nursing home. The nursing home states that a resident, a former patient of yours, is having pain, has not eaten in a couple of days, and is having trouble sleeping. The nursing home and the family is concerned because the resident is starting to lose weight and believes that the dental pain is affecting his overall well-being. For the most part, the resident is bedbound and it's difficult to transport him outside the facility. This is considered asynchronous. The hygienist can go to the nursing home and do a dental hygiene assessment with radiographs and photos and take impressions if needed. The hygienist uses a limited evaluation survey to gather the information necessary for examination. And then there you go. You review the information, you teledentistry, you decide kind of what the correct setting for that patient is for treatment. And based on the patient's health history and ability to tolerate treatment, you decide to place the patient on antibiotics and schedule to go to the nursing home to do extraction on 30/31. A school-based outreach is that the school and your office is invited to do a back-to-school outreach at a local high school. The schedule at the practice is booked up for 2 months. Your office decides to do a teledentistry outreach for the school. The nurse presents with a 10th grader who she says is a high priority. She states that the student frequents her office due for Tylenol because she has a hole in her tooth. The student currently has a fistula on number 19. So you would send digital dental health forms and consent forms before the outreach day. The hygienist goes with an administrative staff member, gathers the student who gave consent for treatment. The hygienist completes the dental hygiene assessment, radiographs, photographs, prophies, fluoride, sealants if needed on that patient, and the dental office blocks off time in the schedule at your office for you to complete the exams on the student. When you review, the outcome is when you review the dental hygiene assessment, you find out that the patient needs a root canal on number 19, and you use your care coordinator to schedule that. And I believe this is where we have the follow-up and patient consultation. The male patient of record was in the clinic 2 weeks ago and had a tooth extracted. He is having some issues with getting food stuck in the extraction site and is wanting to know about tooth replacement options. So you can schedule the patient for a video consultation. You can send a digital patient education video that's emailed to him explaining different options on replacing a single tooth. He's also asked to complete an informational form after watching the video so your staff can get a better prepared for different type of treatment options. And the office staff has prepared a slide deck for a single tooth replacement option ready for the dentist to discuss with the patient. So you know that the outcome is pretty understood, that the dentist and the patient discusses how the extraction site may need to be maintained until the site is healed. The dentist uses the slide deck to discuss the options with the patient and create a treatment plan for a dental partial denture to replace the tooth, as well as one on the other side of the arch. So this is done as a synchronous visit, dentist to patient. And here are different codes that you can use with that also. So we talked about the different applications of teledentistry. Now we're going to actually go into more how to actually do the teledentistry, how to complete an assessment, how to complete the exam. So Dr. Suter and I kind of came up with a 4-phase teledentistry model to keep it really easy for people to kind of go through the steps and create a workflow. So this is our 4-phase teledentistry model. You don't have to use this model. It's not like a textbook thing. It's just something that works for us, and it helps us teach people how to do teledentistry. So this is our 4-phase approach. We have care coordination, data collection, examination, and follow-up. What I can say about care coordination, it happens first, but it also happens throughout the whole 4-phase process. So it's something that you're constantly kind of assessing and doing. And during data collection, this is where the case presenter or the facilitator gathers the actual data needed to do the examination. During the examination, that's when the diagnosing provider actually reviews diagnosis or treatment plan, and they make sure they communicate their findings back to the treatment coordinator or the patient themselves, or whoever, or maybe even the other specialist or provider that needs that information. And then lastly, you have the follow-up where you determine priority by urgency, what type of recall they need, what kind of treatment they need, and what's the care setting to do it in. So we'll start off with going through care coordination. Care coordination is considered the deliberate organization of patient care activities. It occurs between 2 or more participants involved in the patient's care, and it helps facilitate the appropriate delivery of healthcare services. Here, in care coordination, these are the things you kind of want to do. You want to identify social determinants, because this is really important to the outcomes that you have when you do teledentistry, because a lot of times, you're trying to communicate to the dentist because the dentist is not there. They're trying to communicate some of these determinants so the doctor can make an appropriate treatment plan or diagnosis. Really a treatment plan. You need to know the patient's needs or expectations. We find that when the patient feels like they're included and they feel autonomy, that you have better outcomes. Navigation, everyone knows that the healthcare system can be disjointed, so coordination helps patients navigate the healthcare system and link at-risk patients to dentists and address barriers to care. And understand referral sources. It helps close gaps at points of transition of care. So, data collection is the role of the case presenter or facilitator. It's a comprehensive assessment of radiographs, photos, and they must be of diagnostic quality. And through the use of telecommunications, you are able to exchange the information over remote distances for consultation with the dentist. So these are basically the things you do during the data collection phase. You take x-rays, you take intraoral photos or extraoral photos. Those determinations will be determined like when you calibrate with your dentist exactly what type of radiographs, what type of photos they need. You chart and you do detailed documentation. During the examination phase, which I won't go through in very deeply at all because the doctor does the examination, this is designed to develop a complete picture of the dental health. It consists of review of collected information, examination results, diagnostics, and photos, and then it's the communication of the treatment plan and the next steps. So here, the doctor reviews the information, diagnosis, treatment plans, then communicates. Lastly, but not least, is the follow-up. It's one of the very most important steps. It takes participation from all team members and ensures that you keep those good relationships with your patients, especially due to the virtual nature of the appointment. You want them to feel the same kind of emotions that they would feel if they were seeing the dentist in person. So that's why this is a very important step. The patient wants to feel like they're being very well taken care of, and the standards of care of a traditional visit is the same as a teledentistry visit. So, four-phase approach is prioritizing care by urgency. And it's very important that you definitely know what the patient's needs when you're prioritizing by urgency. You have to decide on the treatment, establish a recall, and determine care settings. Okay. Ooh, sorry. Not really sure what happened there. Okay. So care coordination, we're going to break down care coordination. We kind of went over this slide already. Once again, we went over this slide and kind of what that entails in the 4 stages that you do in care coordination, which, you know,
Hey, Tiffany.
I think a lot of times, yes.
Hey,
Yes.
Your screen share turned off, I think.
Okay. Can everyone see it now? Are we good?
Yes.
We're good.
Yep.
Okay, great. Oh, that's the wrong slide. Okay, so we're going to start with identifying social determinants of health. And I think the concept of care coordination, a lot of people, when they think of dentistry, they don't really think of care coordination. But I think especially with the way that insurance is going, where it's not very quantitative, but more qualitative, I think it's important that we start to think about dentistry in this frame. You want to think about how is the patient able to pay for this? What about what's going on is affecting what's going on in their life, and how it impacts their health. You want to think about how they're getting to the dental facility. Do they have transportation? Do they have access to food? Is this the reason why you're seeing so many cavities? Do they have dental coverage? These are things that we need to consider in order to make sure that the patient's satisfied and that they have better health outcomes. I think the better we understand this, the better we can actually help the patient. So when addressing social determinants during a teledentistry appointment, you need to create a process within the workflow to collect and document social determinants. And that kind of happens right when the patient comes in. Typically, I'll say, like, how are you doing? What's going on? Are you having a good day? What's going on with life? So that's a way to kind of get the patient to open up about social determinants. It's important that you analyze health behaviors in light of their responses and document. Sometimes their behaviors don't really match what's going on their health history. So you might want to make sure that they're consistent with what you see or what is documented, and make sure you document that. Get an understanding of the impacts of social economical factors on patient outcomes, and use responses when considering interventions and treatment plans. So all the information that you gather, you want to make sure you apply that when you're reviewing the data, when you're making a treatment plan, and you're communicating with the patient. Patient needs and expectations. Patient's expectations is what the patient hopes to achieve through the care. This is something that needs to be managed adequately in order to improve outcomes and decrease liability. And understanding the patient expectation can enhance their satisfaction level. So I usually share this video with my daughter. I was actually pregnant. I have 5 kids. I was pregnant with my 3rd one, and I had my oldest daughter with me, and she was probably about 4, and I was 37 weeks, and there was something going on with the baby, and I was on a monitor. And she had my cell phone the whole time. She was just like, I need Wi-Fi, I need Wi-Fi. And everyone was laughing, and I'm like, oh my goodness. I'm just like, this is what's going on with I'm a little bit scared about what's going on with my pregnancy. But she needed Wi-Fi at that time, and it was very, very important to her. And so sometimes things that we think are important, that patients think are important, dental staff might not think it's important, but it is important, and it's very important to consider so that you do get good health outcomes and you do get good dental outcomes. A way of kind of figuring out this information about what patient needs and expectations and their social economical factors is doing motivational interviewing. This was kind of a clinical approach that was developed for people with mental health and substance use disorders, and it's something that's used throughout all different aspects of healthcare, and it's commonly used and taught in health programs. So, to move the patient through these 4 processes of motivational interviewing, professionals needs to leverage the 4 core strategies. And I have some examples here of the strategies and things that I use to kind of get through those. So using open-ended questions is the first part of motivational interviewing, ensuring that the patient's doing most of the talking and helping them explore their own thoughts and really help support the idea of autonomy and informed consent, and that the patient is engaged through the process. So a lot of times if a patient comes in, I'll say, like, what can I help you with? Help me understand what's going on with you, and what do you want to do next? Sorry, waiting for it to click, so it might jump a couple slides. Bear with me. Yeah, and it did. Okay, so the next one is affirmations, recognizing key strengths to help the patient build confidence and acknowledge their own successes. So especially with my patients who I know are kind of apprehensive about the process or this apprehensive period, I'll say, I appreciate you coming into the clinic today. I know that's huge for you. So that's my line that I like to use for affirmation. Reflective listening means paraphrasing the client's statements back to them to demonstrate listening and empathy, and also to clarify where they're coming from. So, like, one of my lines would be, I get the sense that this tooth is really bothering you and you want to do something about it, and you have real concerns about your mouth. Another one is, I want to hear what I hear you saying is that your tooth is not really bothering you enough to get it pulled. You just want medicine. And then I make sure I clarify and understand that that's exactly what they're trying to say, or get that point out. Summarizing, encapsulating an entire session to help the patient move to the next process. So a line for me would be, let me stop and summarize what we just talked about. You would like to keep the top left tooth, even though it hurts because it's your main chewing teeth. Yeah, that actually happens. I actually say that a lot. So next is discovering the patient's needs and expectations. You want to create an environment of patient inclusion. You want to be competent, culturally competent. You want to establish an effective line of communication and make sure that you're always actively listening. It's important that calibration of the patient's needs with the doctor's expectations, and I'll give you an example here. So if a patient comes in like this, they might say, like, I want to get all my teeth pulled. I'm just tired of being in pain. I don't want to live like this anymore. I just can't stand it. And I know my doctor well enough to know that ideally he will probably want to extract most of these teeth, but if there's a few at the bottom that he can retain, he will try to retain those. And so I would have to talk to the patient about, well, make sure I'm empathetic and that I'm understanding the patient needs. But I definitely say, yeah, I definitely understand that. Typically in a situation like this, my doc will probably definitely pull most of the teeth, but if he can keep some in the bottom, he will, because it's really hard to retain a lower denture. So if we can keep some teeth and make a partial, that'll be a better fit, and you can chew and eat better. So typically that's what he tries to do in these situations. So that's a way of calibrating the patient's needs to the patient's expectations to what the doctor would typically do in a situation. So navigation, it helps overcome the transitional barriers associated with the healthcare system. It decreases fragmentation through integration, and it takes an established relationship between the patient and navigator. So with navigation, navigation can happen in different levels throughout the process, and typically we recommend that you have a person designated for navigation. Usually, like in our office, we have like a treatment coordinator, and that's who does navigate for us. And these can be different people, but it's important to make sure that you have one person designated. So once, like for instance, in our office, once the patient sees me, and I complete the assessment on the patient, then they go to and once Dr. Shooter completes the examination process, we need one more person to kind of come in and make sure that they get their appointment scheduled, that they understand the treatment options and consideration. So, and so that's where a navigator or a treatment coordinator kind of steps in that place. And lastly, we got referral. We have referral. It's important to create a standard referral protocol, develop clear policies and instructions, have designated staff to monitor referrals, and build a robust and diverse referral resource. So these are a couple of questions that we always like to ask our clients about their referral network or resources. Does your team have an effective resource database? Who is responsible for referring patients? And are you evaluating the outcomes of those referrals and responses? Are patients actually making it to the site of referral? Are they actually utilizing the referral system? Is there something that you can tweak to make sure that that patient actually get the referral or actually utilizes the resource? So those are different things that you can consider. And how do you track this process? Are you using a project management tool? We kind of discussed that in the operating slides. Can everyone still see my screen? Because I see a person there, so I just want to make sure everyone sees my screen.
Yeah, we can see it. Yeah.
Okay, great. Okay. So now we're going to go into data collection. This is the second stage of the four-stage process we have. So care coordination first, now we're on data collection. So data collection is the role of a case presenter or facilitator. It's a comprehensive assessment with radiographs and photos. Must be gathered and must be of diagnostic quality. And you take that information that you collect and you exchange it over remote distances for consultation with the diagnosing provider. Waiting for it to click. So there's 4 parts of actually doing data collection. You take radiographs, intraoral or extraoral photos. What's going to say about the intraoral? They give a good perspective that you can't see on the radiographs, obviously. A lot of times I like to say, typically you see something on the radiograph that you might think it's a radiolucency, but when you actually look in the mouth, it could be like an abfraction, or it could be cervical burnout that looks like a cavity. So those pictures help bring the whole perspective together. Charting, usually you present the doctor with a visual representation of what you actually see in the mouth with descriptive notes of suspicious areas and abnormalities, and then detailed documentation. This really helps identify behaviors that may risk success of compliance with treatment outcomes. Also, it gives you the opportunity to obtain, document the information you obtain, specifics of the appointment to include pain assessment, patient expectations, and contraindications in the medical history. So these are traditional teledentistry data captures. You see, like here's a full mouth FMX. Here's some intraoral and extraoral pictures. These are intraoral pictures that were done with an intraoral camera. You can also do 3D scans, perio charting, tooth charting. Those are different things that we do. We're actually in the process of buying a digital scanner in order to do teledentistry with, and we're very excited to do data capture. At least I am, because I do most of the data capturing. We're very excited about it. I want to see how I can adjust my workflow and how it betters my workflow or what it does. I definitely think that it's definitely going to help the dentist be able to do better diagnosis. So taking X-rays, when you take X-rays, whoever the case facilitator is, they have to have the ability to interpret radiographs. When I do radiographs, I always interpret what I see, whether I know that he's going to see it, but I still write it down. Saw radiolucencies on here, here, here. Saw radiopacities here, here, and here. And I let him know that in my notes. Okay, so different radiograph series that you might use based on what you're doing or who you're seeing. If it's a new patient, you might want to use an FMX. It can detect abscesses or root tips in particular areas, because sometimes a patient might present to you and it might look like the tooth is extracted, but it may not be. So I like to take FMXs when it's a new patient. Continuing care, we typically do 4 bite wings and 2 interior PAs for recall patients. If the patient comes in and they have a chief complaint and they're there for the recall, like I've been having pain on number 3, then probably take a PA on number 3. Emergency patients, typically we take a periapical to identify the chief complaint, and it's obviously very important to make sure the full tooth structure is represented in the image. If we're partially edentulous or edentulous patients that are not new patients, it's important to take a full set of radiographs, even though the teeth may appear to be missing throughout the mouth. The exception is when the patient has a full upper or lower denture. So this is a full FMX. You can see. Here's our different interpretations that you might want to identify radiolucid findings. You can see at the APCs there on number, 31, that there's a radiolucid finding. Radiopaque findings, if you look into like the mesial root there, you can see where the yellow arrow is. That's a radiopaque finding. And then here you have the mixed density finding. And for people who are data collectors or case facilitators, you just write what you see. I see just simply, like I said, like on the first radiolucent, I see a radiolucent area at the apices of number 31. So don't go beyond your scope. So intraoral and extraoral photos, like we said, they give a much needed perspective for diagnosis, and it's an imperative part of the examination process. So the doctor feels like they have enough comprehensive and definitive information to make a treatment plan, a diagnosis and treatment plan. Different things that we use for the intraoral and extraoral photo setup is digital camera, intraoral mirrors, stick retractors, and intraoral cameras. So this is currently what our setup looks like in the clinic until we get our digital scanner, which I'm really excited about. These are the different, I'm going to kind of skim through these, but these are the different kind of photos we take. We typically take like an ortho series, like so if someone who's ever had braces, these are the type of images we take, and we do it to provide the doctor with an orientation they can follow in the mouth, because if you just take random pictures, the doctor kind of doesn't know where they are. So we do it in this orientation so the doctor knows that we're going from right to left and then sextant 1, 2, 3, 4, 5, 6. So we do a front profile view, and that's what that looks like. We do a retracted smile view, and that's what that looks like. And I do it in this exact order. We do a maxillary arch view, like that. We do a mandibular arch view, just like this. We do the right and left buccal views, and that's what that looks like. We do the sextant lingual view, so we go through all 6 sextants from upper right to lower right in order, and they typically look something like that. And I upload those into our system, is that we upload it into DEXIS, and the doctor is able to see it with the patient's radiographs. So with the intraoral dental camera, we don't typically use those because it's really hard to get to identify kind of where you are. So we use those to help highlight a particular area in the mouth. For instance, if I was taking a picture, if I was looking inside the mouth and I saw like a fistula or some kind of pathology, I would probably get the intraoral camera and take a better picture of that for the dentist to see. So, for instance, this is a tooth on a patient that I took an image, and I really wanted him to see the open margins there, and where the amalgam is, I really wanted him to see the crack filling that she has there. So I got the intraoral camera and zoomed in a little bit more there. Uploading pictures, uploading images is very important part of the data collection process. There's several mechanisms for doing it. I just kind of described one, how we upload our photos into DEXIS. We just drag them over from the camera right into DEXIS. It's a really fast process. Just make sure that your method is HIPAA compliant and allows for easy access to the images between providers. So this is what it looks like, the upload into DEXIS. So with dental charting, it's a process of describing the health of the teeth and gums, because sometimes this is, there are some things that won't show up in pictures here, like what are the probing depths, what does the periodontal condition look like. When you present, a visual representation of the mouth with descriptive notes and suspicious areas and abnormalities, and vital for interpretation of radiographs and images. So it like puts the bow on the package with the radiographs and the image, and you chart and you kind of outline what you saw. It really you present a nice package for the dentist to be able to feel comfortable diagnosing. So this is an example here. Number 12, which was that tooth that you just saw with the open margin. Just so he can know what he saw in the radiograph, I would say something like number 12 has occlusal wear, open margin, sticky to touch with Explorer. So that's a note that I would put in the charting. Okay, charting, period charting, so you can know, because obviously we all know that period charting is very important in treatment planning too. And then lastly, detailed documentation. You want to, and we kind of talked about these things already, but just make sure you get like pain assessment, because that's very important in treatment planning, patient expectations. You want to make sure that you're detailed and you specify, and this will really, really help the doctor during the treatment planning process. So when you do your documentation, you want to make sure you note the method for obtaining data, pain assessment, expectations, and contraindications to medical history. When you're obtaining data, your method for obtaining data, you always want to put the time and date, and most times it could be different in states, but what we learn in most states that this information has to be there. The time and date, because most states have a date that you have to have the exam done. So most, like here, we do 72 hours. So the time and date, it's helpful to know when the exam is actually due. Location of originating and distant site, which we probably define that. Dr. Suter probably defined that. But the originating site is the place that that you collect the data, and the distant site is where the examination is done. And that's another legal documentation for per regulations. Also, we have data collection methodology. You want to put how did you collect the data and what did you use, how many radiographs, how many pictures did you take, what dental instruments did you do, what services were rendered. And you also want to put the name of the case facilitator or presenter. Most times, as you saw, like the different types of teledentistry visit, these things can be very, very different. If it's like a limited synchronous exam, and the facilitator might be the patient themselves. If it's here in the clinic for a recall appointment, then I would be the case facilitator or presenter. So just based on the situation, it can be very different. So this is like kind of like a synchronous, and in this circumstance, the patient would be the case presenter, and you will write down the location of the patient's where the patient is. So medical history, I'm sorry. So you want to make sure you review medical history. Also too, as we know that sometimes patients won't identify everything, or maybe they don't know something's going on. So you definitely have to be more cognizant of that as a case presenter or facilitator. I mean, I know I personally feel like a lot more responsibility because I know that I don't have Dr. Suter to lean on to really know, to lean on physically here, even though I always know he's a call away, but I know that I have to pay attention more to these things and be very in tune with the patient and understanding what's going on and making sure that I'm being very thorough. We know, especially in public health, a lot of patients have chronic disorders, and you might see medication, but you don't see a condition listed with it, and those are questions you might have to ask because maybe the doctor, maybe maybe the patient has, for instance, like the patient has like that they have low bone levels or something, and you ask the patient if they're taking medication for that, and they say, yeah, I'm taking Fosamax, and like that wasn't listed in their health history. That might be a contraindication to care that the dentist would not know and would probably get a primary care referral before doing an extraction on that patient. So these are things you have to kind of go through because the dentist doesn't have the opportunity to do that because they're not there with the patient. Medical alerts, you want to make sure that you check for allergies, conditions, especially because in these appointments, a lot of times antibiotics can be prescribed in the setting, in consultation. If you're unsure of anything or you feel uncomfortable with anything, always make sure you consult a dentist or a provider. So with pain assessment, you want to make sure you get chief complaint. That's super, super important for patients' expectations and needs. A lot of times what we think might be important is not. The patient might not feel like it's as important. Pain level, a lot of times pain is hard to assess, so using like a scale could help you assess pain level. So when addressing needs and expectations, you want to kind of address concerns. It's critical to identify and document how the patient ideally would like you to address concerns. Like, for instance, like, because the dentist is not there, you have a patient that presents and you're kind of doing the care coordinations, you're identifying social determinants, and the patient has to have a tooth pulled. And so you're trying to figure out like what the patient wants to do. Do they just want to leave the space open? Do they even want to have the tooth extracted? Does the patient want an implant? Do they want a partial? How do they want to replace the tooth? And so that's important because how can the doctor treatment plan without knowing really how they're addressing the concern or how the patient wants them to address the concern? And so the doctor might treatment plan for the implant, and the patient is just like really not happy about that because they can't afford it, you know. So and they feel like maybe this is not the right place, or maybe the dentist trying to upsell them. So these are the things that you have to really bring into your documentation. This is a time to educate the patient on possible and realistic outcomes. You know, sometimes the tooth is like 75% of the tooth is gone, and the patient's like, "Can you put a filling in it?" Probably not. So these are things that you need to really discuss with the patient. So it's an easier process when the treatment coordinator comes, or you know. These are really good times to kind of collaborate the patient's needs with how the doctor can actually do. You want to identify risky behaviors, like if you feel like the patient's coming in and maybe they're drug seeking, or maybe you know they're not brushing. You see plaque everywhere, and they want veneers done, but there's plaque and cavities everywhere. So you need to identify those and make sure the doctor knows what those risky behaviors are. Or you might smell like alcohol in their breath, something like that. You need to definitely make sure that the doctor knows those things. Identify the assessment. So it's really important to tell the patient that this is an assessment and not an exam. If the patient feels like it's an exam, they might not receive comprehensive treatment. Plus, obviously, they won't receive comprehensive treatment because there's nothing diagnosed, there's nothing treatment planned, there's no follow-up that happens. So you need to make sure that you you say that the assessment is being done by a dental hygienist and this is not an exam, the doctor will do the exam. So this is kind of one of my documentations and things that I would put in there. I put occlusion in there just so, because that might be important to treatment planning. Obviously still do soft tissue exam, extraoral exam, hygiene assessment, and so you know that I have the chief complaint here. My top tooth hurts when I drink cold stuff. And so you see different things. I put like the different things that I use: Explorer, periodontal probe, radiographs, intraoral, extraoral photos. Patient did great, has had anxiety in the past. As far as patient goes, patient understands that she may need a fill in her crown. Patient had knee surgery. Due to hospital bills, patient is concerned about the amount of possible treatment. May want to start with the options that might get her out of discomfort. So that would be a typical note that I write to Dr. Suter. So last but not least, we have follow-up, the most important step. And between data collection, obviously, and follow-up, there's examination. But Dr. Suter probably talked a little bit about that in his presentation. So I don't really go over that part. So we're going to go ahead and jump to follow-up. So follow-up takes participation from all team members, and it really ensures that there's a long-lasting relationship and that teledentistry doesn't turn people off. It has to be done the right way for sure. You want to prioritize by urgency. A lot of times the needs are numerous, and some patients need to prioritized for follow-up care. It's important to decide which needs to be addressed first. Treatment. I think it's really good to have different options for treatment because that helps the patient feel like they're giving informed consent and they're included, and it helps increase patient engagement in the process, which I really believe helps treatment outcomes. You want to establish recall. Recall is important to establish in a dental home, and it's important that it's consistent and comprehensive. And determine what care settings. Based on the follow-up needs, the care settings may vary. It's important to weigh the advantages and disadvantages of follow-up care in different settings. So, things that you need to take in consideration with prioritizing care. Ensure that the patient's needs and expectations are taken in consideration. Like, for instance, you might see a large fractured tooth on number 15, but the patient's really concerned about, maybe that's not a good example. Maybe you might see like a really bombed out tooth and the patient says they have no pain on number 15, but number 7 is fractured. And to the patient, number 7 is fractured. They feel like they can't go to work. People are staring at their teeth and they have a hard time smiling. So those are situations where you might need to prioritize care based on the patient, what the patient's needs and expectations are. Can you help engage better? This can help engage better targeting of scarce dental resources to those who need the most. And you typically see this in schools where it's important to make sure you triage patients based on their needs. Like if we were in school, we had patients with a couple of our kid patients with abscesses. Those are the kids that would get priority for treatment while the doctor is there. So yeah, those are really good points. Operative treatment generally proceeds from the most to the least involved teeth. Treatment of the chief complaint of dental pain will take precedence. certain functional and aesthetic considerations may be dealt with early dealt with early in the treatment, what's indicated, like broken teeth, even though they're not painful. And we'll call for some treatment to relieve the patient from discomfort, like sharp margins. Sensitive teeth and areas of food infection may also be treated early. So these are things that you can take into consideration. And I feel this a lot when taking down chief complaints, because coming from public health to private practice, sometimes the chief complaints are really different. I went from patients that were in extreme pain, like abscesses everywhere, every tooth fracture or broken, to like, oh my gosh, my teeth are not very white when they're very white. So sometimes I really feel that way. So establishing a recall system, you want to make sure that that you utilize dental marketing or recall marketing or practice management or care coordination software. You want to make sure you monitor your recalls, and remember that good recall is considered best practice. Treatment. When you're looking at treatment, you want to make sure you control, eliminate active disease such as caries and inflammation. You want to make sure that you have informed consent. You want to make sure that you stabilize the patient's dental health. And you want engagement. You want to help improve outcomes and increase patient satisfaction. Care settings. So this shows some different care settings. This is me in the nursing home with a wheelchair lift, and I'm seeing a patient for prophy in the conference room. So that particular treatment is something that we would not take a patient out of the nursing home for. For some of our patients in the nursing home that just needed dentures, they were edentulous and just needed dentures. We actually did dentures in the nursing home, and this the second picture is an image of our denture cart, where we would take impressions. They had all the materials needed for Dr. Suter to adjust and do the wax buildup and all those different stages for dentures. And this is one of our doctors, Dr. Olga. She's doing an examination in a room. So you have to really determine what the best care setting is. Here you can see that I am in a patient's room doing data collection, taking intraoral photos right in her room where her bed is. The second picture is a picture of Dr. Suter. I was here and he was in Seattle. I was at the office and he was at Seattle, and we had an emergency with one of his implant patients, and he actually did the examination in an Uber in Seattle. And this is a rural middle school, their weight room. This is where I set up to do some teledentistry assessments. So when care coordinating, we like to use coding to help us organize and facilitate the follow-up. A lot of people don't know that the ADA came up with some dental case management and care coordination codes, and we really like to use them. And sometimes we use subcoding to help the treatment coordinator or the care coordinator know what to do with the patient next. So after the doctor treatment plans, he might use one of these subcodes to let the treatment coordinator know what they need and what they may need next. So here's some other ADA supported coding for follow-up. You might use the D9311, and that's if you consult with a medical health professional. There's a few different ones for case management. That motivational interviewing that I was talking about, we use the D992 and then D993 quite a bit. And like I said, it's a quick way to communicate follow-up care. And our model is to ensure that there's follow-up care. You may need to ensure proper documentation and we recommend 3 attempts at follow-up, especially in school programs. Follow-up can be very, very difficult, so we definitely recommend at least 3 attempts. And that is it for my presentation today. I don't know if Dr. Suter is on here. Maybe he's not. I wasn't sure if he was going to come in, but I'm ready to open it up for questions.
If there are any questions for Tiffany, feel free to type those in the chat box.
Yeah, and I have a few questions too, if for the crowd.
Can I ask a question live? Can you hear me? I don't have a chat box,
Yeah.
so I'm coming through a phone.
Yeah, I can hear you. Great.
Hi, Tiffany. This is Valerie from your 2017 class. Great to see you. Great presentation.
Thank you.
Yes, I have a question in regards to, I just got notification yesterday that, where you are, obviously the hygienists can do these assessments, but other states that are with legislative, there's constraints to using teledentistry in other states.
Yeah.
Do you foresee this getting better based on what I heard just yesterday, that ADA actually has they're trying to go against using teledentistry at their meeting coming up in October. So I wasn't sure if you had any information on what we can do to help support this, since this is such a, it's the future, it's the now, and it certainly is helping us reach the communities that are untapped right now. So do you have any background or any information on what's happened currently with legislation?
Yes, so the teledentistry definition will be brought up at the ADA's House of Delegates. There's some dentists wanting to change it so that they eliminate the asynchronous, from my understanding, and make it where it's just synchronous. And this is really because some things that we saw with the Smile Direct and how they use asynchronous and the problems that occurred with that type of teledentistry. And so we do have some people, like Paul Glassman is working with some of the ADA delegates to help kind of hammer this out. And I know Dr. Suter is aware, and he's really a really big advocate, and he's working with ADA too to help kind of see what we can do to stop that. And it really impacts the asynchronous versus the synchronous. So.
Okay, yeah. Great. Thanks so much, Tiffany.
Yes, no problem. So do you use extended care facility code D9410? I don't think I've ever used that code for extended care facility code. I'm not sure what that is, Sarah. I'm so sorry. Maybe you can explain a little bit in the chat box and I can help out. It says, do you treat nursing home residents who are current patients of record only? Have you done screenings in a more general approach at a facility? So when Dr. Suter and I first did our teledentistry pilot, we did a pilot in a rural elementary school, a middle school, a high school, and a nursing home facility. Thanks, Sarah. And so, during that, we had patients sign up for the program at the nursing home. And when they sign up for the program, I just went room to room doing dental hygiene assessments where I do the data collection and transmitting over to the dentist. So that's typically was our approach at that particular facility. We've also, so I wouldn't say there were screenings, and be careful with this because a lot of times in outreach programs you do screenings or assessments, but assessments are a little bit more detailed than screenings. So if you're going through that full data collection process, you probably want to use more of a hygiene assessment code versus a screening code. Have you done screenings in a more general approach at a facility? So I would say that's what my job there was. Assessing, I think, how many patients did I have in a nursing home? Maybe 100 or so. So maybe I did 100 assessments in that nursing home or screenings in that nursing home. And it was one of my favorite places to work at. And the patients really look forward to me being there. I had one patient she kept losing her dentures, and her daughter was upset about it. And as soon as we got her some dentures in, she wore lipstick the next day I saw her. The next day she got her dentures. So it's a really fulfilling place to work at the nursing home. Can you do cleanings at the first visit at a nursing home, or assessment first and schedule the cleaning on a later day? Yes, based on Missouri Practice Act and rules and regulations, that the patient has to be a patient of record before you can do a cleaning, or have had an exam within 12 months. So you can't do the cleaning first unless they're a patient of record of the doctors. So it just depends. If they're a new patient, then no, you have to do assessment first and let the doctor do the exam. If they're a recall patient, then you can schedule the cleaning and assessment at the same time. So, hope that answers your question. Does anyone else have a question? Sarah's talking.
Oh, I guess so. Hello.
Yeah.
So I'm looking at opening a teledentistry business in my area. So I was kind of trying to do some legwork on like what Medicaid would reimburse. And maybe I'm getting ahead of myself, putting the cart before the horse, but I'm good at that. But like my husband used to do an X-ray mobile unit through the hospital, and they had a code for going to the facility. So we kind of looked it up, Googled it ourselves, again, cart before the horse, and he found a code, the D9410, for extended care facility, and it looked like Missouri Medicaid would cover it. So that's why I was asking about that specific code.
You might want to ask Dr. Dane. If Dr. Dane is on the call, he probably could answer that question a little bit better. Dr. Dane, are you still there?
And I've been emailing Dr. Dane about getting the teledentistry up and going in my area as well.
Yeah, can you hear me? I'm here. Can you hear me, Tiffany?
Yes, we can hear you. We can hear you.
Okay. That code that you're talking about is not a dental code. And so you can use it, but it will not get reimbursed. It won't give you any particular advantage to use it on a dental claim. So
okay.
Okay.
Thank you.
And Sarah, too, just for your FYI, I mean, if you find a partner in dentist, you can do what you're saying. You probably have to come up with some kind of agreement, because for hygienists, you can't really bill for it. In the state of Missouri, it's difficult too. So find a partnering dentist, and you can do something like that for sure. Definitely could be a reality.
So I found a dentist. He's still not 100% sure. He wants to hear more, but he just recently retired, so he's not working in a practice. But I would not be able to bill myself. He would have to bill under the supervising dentist, correct?
Yeah, it's easier that way for sure. Yeah. So.
Okay. So he would have to bill and then pay me, basically. I'd still be an employer, not the owner.
Can I interject? This is Nathan.
Yes, Dr. Suter.
Thank you.
Yeah. So like, there's a couple ways you could do it. Like, you and he could get a couple more members, and you could make a nonprofit around it. That's a possibility. And the nonprofit is the one that does, the billing under the dentist's NPI number. And you guys could both be, employees of the nonprofit. That's an
Okay.
option. Um, that's probably what I would suggest to go with. You guys could you could make it a for-profit, in the corporation bills it out under the dentist. Like, you guys are both members of the corporation. There's possibly a way to do something to that effect. But a dental practice has to be either a nonprofit in Missouri, or it needs to be majority owned by a dentist. So
Okay.
that's so he would have to, you and he would have to like create a company, and come up with an arrangement. Either way.
Okay. Good. Thank you very much.
Dr. Suter, do you have
Yes.
any other remarks or anything you felt like I left out?
No. I just wish we could do it in person so we could kind of bring some stuff in like we did the last workshop, but not possible these days. So we appreciate everybody sticking out for, the 4 hours to do the course, and hopefully you guys could take away a lot of nuggets, and helps you get on your path. If you're looking for more information, feel free to reach out to Tiffany and I, or Dr. Dane, who's putting this presentation on with Gary, and the department can maybe guide you to whether or not there's more resources or not to help you get started.
Yeah, and I also wanted to, I noticed that we had a lot of students in the webinar today, and I just wanted to ask, like, what are their thoughts on teledentistry? If this is something they're interested in incorporating in their practice? I mean, like, I'm just curious. Someone willing to tell me? Anyone out there? No? No biters. Is Julie still here? Maybe you can tell me from an educator perspective why you brought the students here. No. Well, I don't have anything else. I thank everyone for, we have some stuff going on here.
I'm one of the
Okay.
students. What was the question again?
So why was this a webinar that you were interested in? And did you see anything that you felt like maybe you would want to incorporate when you become licensed, or, and do you feel like your education's kind of prepared you to do this type of dentistry?
I feel like the big draw for this one for us is the fact that it could bring care to a lot of people that may be in remote places or may not otherwise be able to access care. Like you mentioned, the healthcare barriers, and this kind of helps with some of those issues. I think that I definitely think that I want to see how teledentistry develops, because I still have some like weird feelings on it. I don't know, like there's a lot of gray stuff, I guess, that just seems kind of fuzzy sometimes, or I don't know. It might just be that I'm stuck in the thought pattern of like how it all used to run. I don't know. But that's kind of my
You're
take
not
on
the
it.
only one. You're not the only one at all. So that was good feedback.
So
Yeah, you're definitely not the only one. And I like to just lay out. I usually like to lay out an illustration that, like, the teledentistry isn't really one thing. It's just a tool to do what you're doing, and look at your practice and look what benefits. Two of the most biggest uses of applications of teledentistry, telehealth. If we could look to telehealth, who's been doing this for 2 decades, is provider to provider. Sorry, I've got a little one right behind me. Provider to provider consultations on their patients. And in medical, you're able to bill for that. So like if there's ways for us to push and advocate for you to collaborate and not have siloed dentists, able to collaborate with their peers on cases to get patients access to the best doctor for them. That's one way that medicine is using it. And then another way is the other biggest thing that telemedicine uses is monitoring stroke patients. It's teleneurology. So like if you're able to take really good care of hundreds of patients at a time who have just suffered strokes, and their life, they're in critical care, and doctors are able to monitor them with telehealth equipment and guide other doctors to or nurses or PAs. Like, we should be realistic about what our expectations are with teledentistry and see, like, if people with brain injuries are getting treated, there's no reason you can't rethink of the way that you're practicing and see that there's applications beyond. I physically have to touch every patient and I have to talk to every single patient eye to eye to help them get healthy. That it's not. That mentality is what restricts healthcare access, okay, in general.
And I also wanted to note too, the dental delivery model is changing, and I think we need to be more on top of it, or other people are going to make the decisions on how we deliver care. So I think we got to wrap our minds that a lot of patient demographics, they're finding different ways to get their dentistry done. It's not in the traditional way of like coming into a dental clinic in the traditional 4 walls. So in order for us to stay pretty much employed, I think we got to think outside the box and find a way to go to our patients versus our patients coming to us. You see a lot of dental patients that end up in primary care offices and emergency rooms and FQHCs. I think we have to keep that in mind and try to adjust to those changes of how people are seeking dental care. Yeah, that's it. Something I would want to do would be the hygienist-dentist relationship available over teledentistry. I think it would help decrease healthcare disparities because the hygienist would be able to go out in the community and provide access to care. I totally agree too. I did have the opportunity to work in a primary care office because of teledentistry, and I do think it does help health outcomes because sometimes, even though the primary care provider is trained on the whole body, sometimes they just don't feel comfortable with the mouth. From my experience, a lot of times they were very happy that I was there. And also, too, I think it did help close gaps in our healthcare system because if a patient came into primary care, the only thing they can really do is some type of palliative treatment, give them pain medicine or antibiotics, or send them to the emergency room. So if I was there, I was at least able to take a radiograph and schedule them for a dental appointment to see a dentist. And that was the only person that can really give them comprehensive care and treatment. So, it's very interesting, and I think we have to kind of get out our comfort zones, our dentistry box, to actually be able to access and treat our patients and treat the patients that need us the most.
This is Gary. Dr. Burnett wrote, I think everyone is interested because of COVID. We definitely saw an uptick of interest in teledentistry when COVID hit. It's a terrible pandemic, but it has opened things up a bit for innovation, and we're certainly trying to capitalize on that as a coalition because we do think it will increase access to care, which probably access to care issues have been intensified a bit because of COVID-19. Dr. Dane and Dr. Suter and others on here might disagree with me, but I sort of feel like once a practice is acclimated to the new procedures and all the extra PPE and all that stuff, they're probably landing about 85% of capacity compared to pre-COVID. And that collectively means a lot less dental capacity, and I think teledentistry is at least one way to make up for that. So and people do seem to be very broadly interested in it and picking it up. So we're very happy with that.
Well, we are very, very grateful for your time. We always are very grateful for opportunities to teach people about teledentistry and be around like-minded people, and know that you can always reach out to us with our via our website. We also have a Facebook group page called Mouth in the Cloud. Please be sure to join that. That's a community of different dental providers who do teledentistry, and some facet are trying to learn how to do teledentistry. Our website is www.accessteledentistry.com, and we also have an Access Teledentistry face page. We just don't do the consulting. We do a lot of advocacy work. So if you're in different states and you need help looking at practice acts or legislation, we do that too. Just let us know. We're kind of like jacks of all trades. So if you need some help.
Tiffany and Dr. Suter, thank you again for all of your hard work with this webinar and the great information that you provided. The verification code for the CEs for CE Zoom is teledentistry. It's all lowercase. If there are no more questions, I think that will conclude today's webinar. Thank you, guys.
Great job, Tiffany and Dr. Suter. Thank you so much. We're going to go ahead and shut it down now.
Thank you.
Hi, could someone in the chat type in the verification code? I'm having trouble with my audio. It keeps on cutting out. So please, thanks.